Greetings from Chicago, everyone. I'm very happy to give the presentation COVID-19 Update, an Allergist Immunologist Perspective. I'm Paul Greenberger. I've been a faculty member at Northwestern many years. I'm in the Division of Allergy Immunology in the Department of Medicine in the medical school. There are no conflicts, but I do get royalties from Wolters Kluwer for reviewing for up-to-date, and a book royalty and research support from the National Institute of Allergy and Infectious Diseases to Northwestern. And I serve on the Allergenic Extracts Advisory Committee of the FDA. I know many of you are not in Chicago, and I'm recording this on April 17th. I can tell you good news that the White Sox and the Cubs are both tied for first place. The objectives today are three: to discuss updates regarding the COVID-19 pandemic, to explore aspects of coronavirus relevant to COVID-19, and to consider pressing issues, difficulties facing clinicians and approaches to next steps. Professor Evan Scott had asked me to give a talk for you, and I hope this is something that you find of value. What are goals? There's a pandemic right in our faces worldwide. First, prevent deaths, prevent ICU admissions, prevent hospitalizations, prevent ER visits, prevent long-term harms in the survivors, whether from disease or treatments, and reduce the transmission of infection. That's one of them, a big one. Protect healthcare workers from death, COVID-19 infection and disease, and psychological stresses and burnout, which is depersonalization, not caring about the patients anymore. Identify effective immediate therapy and longer-term approaches. Develop methods to identify the pre-symptomatic, asymptomatic, and symptomatic people. And to support and defend the scientific method against what I call gut feelings. You may well have already heard a lecture from an expert at Northwestern about the coronavirus. The crowns on the outside is where the name came from. And there are non-structural proteins that may be targets for treatment. In this slide, the structure has been identified. It's a hexamer, and the virus's name is SARS for Severe Acute Respiratory Syndrome Coronavirus 2. The areas in red are thought to be active sites. Now, I would like to just put some things in perspective, so I like to do it with questions. When we think about the droplets, which has faster speed, a sneeze or a cough? Turns out a sneeze, 100 miles per hour of the droplets. The virus is on the droplets fall to the ground, but aerosols may stay airborne for longer. The aerosol particles are smaller. A cough is 50 miles per hour. Both of them are enough force to cause a fracture of the rib, and I've seen that happen in some patients either from sneezing or coughing. And I want to make sure you know about what is called R0 or R0. This is the basic reproduction number in unimmunized people. If you look at the middle of this slide where it says SARS, Severe Acute Respiratory Syndrome, in the yellow is the person who's ill, spewing out virus. And the data are identified that show about 3.5 people are susceptible and will get the illness from the individual. So that's numbers 3.5 for the R0. If you look up in the one position, MERS, Middle East Respiratory Syndrome, it shows that are less than 1. So this one means it's not as likely to spread. If you look to the right in the 2 position, influenza shows an R0 of 1.5, Ebola 2. The COVID-19, which is in the second row on the left, shows a number of 2.5. That's an estimate now. In some cases, it would be much higher. Now, if you look over on the right, mumps, for which there's immunization, it has a much higher number. And the most extreme example is measles, which is airborne, and it has an R0 of 18. Smallpox is very high, as you can see. Now, from the perspective of history of these coronavirus epidemics and pandemics, I have this slide that shows the SARS, MERS, and COVID-19. SARS was identified in 2003, 8,000 persons affected. Notice the fatality rate, 9.5%, very high. The R naught is 4. For the MERS, which was 2012, it's still circulating. They even have a higher fatality rate, 35%. And the spread is less because the R naught is 1 or less. That helps. But here we are with COVID-19, identified in December 2019. It's still spreading. Fatality rate, approximately 2 to 3%. It depends on the population, but that's a number. The R naught is thought to be somewhere between 2 and 3. And I want to make sure you appreciate that the pathogens like influenza virus and SARS-CoV-2 that make people contagious, they have this happening before they actually feel anything, before they have symptoms. This can be referred to as stealth transmission or pre-symptomatic period. And it's so far appreciated to be 1 to 3 days before the cough, shortness of breath, achiness, or fever. So anything that would identify itself to the patient. And for the SARS coronavirus 2, the mean interval between the onset of the illness and hospitalization so far has been 9 to 12 days. And in China, there were very few children or adolescents under the age of 15. Here's an example of the prototype patient with the infection. In Wuhan, China, which is a city of 11 million people, it was a 55-year-old patient, presents with a non-productive cough, meaning no sputum, fever, dyspnea means difficulty breathing or shortness of breath, and the person can progress to severe and fatal pneumonia. It's infrequent in children, but I will comment that there was an infant that died in Chicago. It's not clearly increased in patients with asthma. That's an area where I take care of many patients. And it's not clearly increased in patients with primary immunodeficiency. And this is a set of diseases. I also take care of patients. So these patients have defects in their immune system and are susceptible to pneumonias and other serious conditions. Healthcare professionals are impacted in different ways. For example, in Wuhan, I become aware that there were 24 physicians who have died. Some were criticized by the government because they alerted the public about the illness. In Italy, 100 physicians have died. Also 100 priests have died. So tremendous catastrophic loss. In the US, healthcare professionals have been accused of stealing protective equipment, while many work unprotected or with non-recommended usual measures. For example, masks worn from patient to patient all day instead of a mask being replaced after an individual patient. There certainly are exceptional efforts and ultimate sacrifice to care for sick by many healthcare professionals. And there are difficult decisions that have to be made at some facilities. For example, one of my patient's wife asked me, will there be a respirator at Northwestern Memorial Hospital for my 82-year-old husband? This patient has had a stroke. He lives with Parkinson's disease. He has hypogammaglobulinemia, meaning he doesn't have enough antibodies to fight infection. And I have to give him what are called scheduled rotating antibiotics every day for a month at a time. Then we rotate him just to reduce the sputum and the repeated pneumonia. So he's not a healthy person. And the wife is asking me an end-of-life type question. The question also has to be, well, what if he has chest pain and might be having a heart attack or myocardial infarction? What would be the approach then? So these are questions that need to be asked, and people need to be comfortable with getting some response in their mind. And I'm not the primary care physician, but the patient asked me about it. This slide talks about the impact of society on society of epidemics and pandemics. Stigmatization. This follows on the heels of every pathogen. For example, anti-Chinese hostility has been a recurrent problem. It was with the plague in San Francisco in 1900, SARS in 2003, or COVID-19 today. Jews in Europe were blamed for the bubonic plague in the Middle Ages. SARS-CoV-2 can grow in mammals like bats, pangolins, and humans. Meat from bats and pangolins is served in restaurants, and pangolin meat in Vietnam is a delicacy. Pangolins are sold in open markets where the spread of the virus from animal to human can occur. Physicians and nurses die in all epidemics and pandemics. I wish it weren't true. The second wave of infection of COVID-19 will come, as it did in 1918 and in 1957. So this is essentially assured. And essential workers are in lower socioeconomic classes. They suffer illness and succumb disproportionately. I show you a picture from an emergency hospital in Brookline, Massachusetts, where patients were cared for during the 1918 influenza epidemic. There's a doctor over there with a coat. There are some nurses with their masks. They have individual tents, I assume. For those of you not in Chicago, McCormick Place has been transformed into a hospital with many locations in separated areas for patients. And this isn't, to me, that much different than 100 years ago. So now I have a question. One of my patients, who's 61, asked me to allow her to walk by the medical ICU to be infected so she can get it over with. She said she'd thought about this and wants to do it. I don't have any way I would take her up there anyway. But what are 4 fallacies in this approach to build immunity? Her hope is to build immunity or protection. I know you can't answer, but I can give some answers. One is she might get very sick herself and could succumb. That would be the worst fallacy. The second is she could spread the virus if she gets ill. She might not get symptomatic, but could be pre-symptomatic and then infect others. And her illness could tax an already overburdened healthcare system. There's another one. She won't become infected. As at our hospital, Northwestern, they have negative pressure ventilation on whole floors so that the air is drawn up through the vent, it's filtered, and it goes out, but it never goes back in the hallway. And there's personal protective equipment in use by the healthcare professionals. But people come up with all kinds of approaches. Here's what happened in a long-term care facility in Kings County, Washington, reported in New England Journal, March 27, 2020. This is an example of 3 weeks. The number of cases on the y-axis, state reported. Among the facility residents, 118 were tested, 101 positive, 17 negative. The case fatality rate was 33.7%. How tragic for the people and their families. In colors, they show who was affected, residents in blue, the healthcare personnel in yellow, orange, and then visitors as well over the 3-week period. And all kinds of people, as you can see on this slide, from different job titles were affected. In other words, everybody, physicians, case managers, the person that cleans the floor, and other professionals. And when it was looked at more carefully, the transmission and spread is shown from left to right here over 2 weeks. Facility A, 2 patients were transferred, so that within a week or so at facility D, C and D, they were transferred over there. The shared healthcare workers, because people work more than one job, spread it. And you can see from this slide how the spreading occurs. In Chicago, there was there were 2 family gatherings with 16 people. There was a birthday party and a funeral. 16 people involved, 3 deaths. And this supports the physical distancing. That's the correct term for it because it's not social distancing. Now, I want to go over some of the investigative approaches because there's much under consideration and we need something that's effective and safe. For example, antiviral medications, that makes sense from one perspective. Lopinavir is a treatment that's given along with ritonavir. Interferon 1 beta would boost the immune response against viruses. There's a polymerase inhibitor called remdesivir. Northwestern is part of that study. Anti-malarial treatment, chloroquine and hydroxychloroquine. This blocks viral entry into cells and attenuates the production of what are called cytokines, which are inflammatory proteins. Hydroxychloroquine's a medicine I have a number of patients getting for severe hives where nothing else works. Patients with arthritis and lupus receive that medicine, and President has pushed this one, thinking, what do you have to lose? A monoclonal antibody, tocilizumab, anti-IL-6 receptor. This one reduces the leaking of fluids into the lungs when a person has pneumonia. So there's rationale for using this. Monoclonal antibodies target the virus to capture it. Hydroxychloroquine plus an antibiotic, a vaccine, of course, and then hyperimmune globulin. This is convalescent plasma therapy. So a patient who does survive is able to donate their blood. The patient has to be negative for HIV, hepatitis, different types, syphilis, and meet criteria to be a healthy donor. And then that way the recipient who's ill with coronavirus receives immunoglobulins in the plasma from the donor. This is under experimentation. Here's an example that's worth looking at from the antiviral therapy in patients hospitalized with severe coronavirus infection. The y-axis shows the cumulative improvement rate. 1 is 100%, 0 is at the bottom. The days are 28 days. When you report data from studies, you put the number of people in each treatment group. So the intervention group at the bottom, and then the control group. So they start out with 100 patients. There's no change at all to about a day after day 8, as you can see. And if you look over the 28 days, there is improvement in both groups and not a significant difference. So the antiviral therapy didn't make a huge difference. Notice what happened, though. They lose a lot of patients along the way, and only 22 and 30 people were in the study at the end of 28 days. So one has to say, what's going on? One thing the authors put, the overall mortality was 22%, which was about double what's been reported in literature, meaning they had very severely ill patients, and maybe the drug wouldn't work in those patients. But this is how data should be presented for those of you doing clinical work or when you get involved with them. I want to point out that pharmacokinetics, in other words, the action of one drug with another, ritonavir, which is antiviral, is paired with lopinavir to increase its plasma half-life through an inhibition of an enzyme. So lopinavir allows for a greater half-life of the antiviral therapy in the hope that it will be effective. And this thinking is something well recognized in what's called pharmacokinetics from the field of pharmacology. Some of you may be taking a nasal steroid, fluticasone, sold as Flonase for allergies. Ritonavir retards the elimination of a standard nasal steroid that's fluticasone propionate to a large degree. But one of the other products for nasal steroid use, fluticasone furoate, different chemical, is not affected very much at all. So even for a medicine that is used in the nose and sold without prescription, there can be interactions. These are examples of a drug interaction which reduces elimination of the primary medication and boosts the Cmax, or the concentration in the blood, that's the maximum, and the half-life. This can prove beneficial, as in the coronavirus study, or at least they hoped it would have, or harmful if there's toxicity. So these are principles to keep in mind as you do some of your research. Regarding research, we want to have effectiveness, which is meaning the patient's going to improve compared to a control group, and also safety. One issue with hydroxychloroquine is the eyes. So the patients have to be checked yearly. The yellow part is the part that's very important in eye. And there's a bullseye at the arrow, and that's toxicity from this drug. So that person has to be observed for that. And from the cardiology perspective, cardiologists always have warnings for interaction on the heart, of course. The drug is usually safe, but there can be arrhythmias, meaning abnormal rhythms, or loss of the normal rhythm itself. So it's not completely risk-free. So at this point in the talk, I want to review for you or introduce to you what is an antibody, since people talk about antibody tests. This is in green at the top is a Y figure, and the part of it is the weight is pretty large, 150,000 Daltons. Albumin, which is a protein, is 68,000 Daltons, and penicillin is 3,000 for comparison. The FAB part is the meaning fragment antigen binding. This is the part at the top of the Y that binds because it recognizes bacteria, viruses, proteins, or medications. The bottom part, the crystallizable part, or FC, binds to cells. So on the top of the Y, if that's directed at the virus, the antibody can bind to it, and through the FC part, it binds to cells. So a cell could engulf the virus and then kill it. Here's an example of what can happen in a study for your introduction to this topic. This is with a typhoid conjugate vaccine treating typhoid fever, which is an issue in Nepal and other places. And what we see is TCV, which is typhoid conjugate vaccine. And the comparison shots giving to the research subjects was a meningococcal vaccine. You probably had your meningococcal vaccine when you were 18 before you went to college. We have day 0 and day 28 when blood is drawn after the shot. And notice the geometric mean in the titer of this antibody goes from 7 to 2,000. So you see a 300-fold increase. This is what we like to see. And we see that of the patients who quadrupled in their amount of antibody against this typhoid conjugate was 99%. This is what we're looking for because we anticipate effectiveness of the treatment. The comparison group, just 2% increased their titer by 4-fold, and there's no change in the geometric mean because they got a different vaccine. So the vaccines are directed at a target. There's a huge surge by the immune system over 4 weeks, and this translates into benefit. All right, now I want to continue on the clinical trials toward the end of this talk. How would we plan for trials in patients with different or other comorbidities, like other conditions? What would be the inclusion criteria and exclusion criteria? So it comes down to how will SARS-CoV-2 affect patients with different clinical conditions? People may not benefit as well with one condition or another. Asthma or COPD, or mild asthma versus moderate and severe asthma, for example. We know more people seem to do poorly if they have diabetes, if they get the COVID-19, heart failure. I've already mentioned immunodeficiencies. There are many survivors of cancer who have had radiation to the lungs. And how about exposure once or repeatedly to younger people, like sailors on a ship? As of now, 4,000 sailors, 600 are positive, and sadly, one has passed away from an outbreak in the US Navy. I'm going to move forward to the condition that I take care of a lot of patients with, asthma. We break them out according to what are called phenotypes. These are observable characteristics like obesity or response to an inhaler, or the cell type, which is shown in the characteristic, and reading across the top, there's 6 different patterns. What we don't know is how the virus could affect any of the 6 groups of people by the phenotype, but this is something that's going to have to be studied. And this is shown to show you how, when you're thinking about studying something, you have to break down your research subjects and your population. Now I want to finally talk about something else going on, and that's the anti-science voices. So this is a change, at least from this talk. The continuing anti-science voices get loud and tempting to believe in a crisis. We're seeing that now. But how do we approach our thinking to really make it critical? So I have 6 bullet points for you, and I've used these over my career. Is the notion or hypothesis plausible? Does it make sense from a mechanistic point of view or biologic point of view? Does it have a scintillating part to it, for example? That's what you want. And your faculty can help you come up with a good idea, or you have one yourself. Is the methodology appropriate? Are there enough experimental data for the study? For example, intention to treat means those 100 people that were in the study I showed you. Per protocol means 28 or 22 that finished the study, and the interpretation really should be on the intention to treat. Is the analysis objective? Have the results been overly interpreted or overinterpreted? People can have a bias. Have risks been assessed properly and reported? I'm a physician, I don't want to hurt my patients. Consider the following randomized trial. This is something called impact of reflexology and homeopathy added to conventional therapy of asthma. It was a randomized trial, and they wanted to test out reflexology and homeopathy. These are not expected to be helpful in terms of reducing airway inflammation. 84 patients. There was a single study. It was by investigators who were blinded. It controlled 1 year, and the people got their regular treatment. And here's an example of some of the thinking on the hand, that it's connected somehow to the head or the left lung or the bladder. I would not accept that this is likely to be effective, but this is something that was studied. And the study has 3 treatment arms: reflexology plus conventional treatment, homeopathy plus conventional, and it's 52 weeks. And then some measurements are made. The top one is for eosinophils, which are allergic cells, and they have week 26 and 52 for comparison. And then nitric oxides measured in expired air as a sign of inflammation. So what do we see? We don't see any change. This can happen, negative results. In this case, it's important because it refutes the notion that there's something to these other therapies in terms of impacting asthma and its inflammation. So to summarize, physicians and scientists need to advocate for well-controlled studies to test plausible hypotheses to avoid overinterpreting results. There's academic bias. We have to avoid against this. We have to consider harms and safety issues in the perspective of efficacy, meaning better than a placebo, address the logistics of implementation, and be aware of costs. And finally, for you, I know none of you, or not too many, are on campus. Look up one special question each day. Even 15 minutes of reading adds up. When you think about it, that's 7 special questions per week. Don't underestimate sleep. Get feedback about your ideas, experimental methods, and findings. And just keep in mind, negative results aren't always of negative value or unpublishable. And I wish you all the very best.